Okay, so today we're going to look at some PET and SPECT applications in cancer and SPECT CT, PET CT in cancer. You'll get the idea pretty quickly, like why they're valuable and also why the inclusion of CT is an important feature often. And then I thought we would look at a couple of things. I got some inquiries from students about the definition of signal to noise, the definition of contrast to noise, etc. So we can look at the homework 1 solutions and just, I mean, it's kind of in there. And so we'll just look at that as an example to get that down, because that's, you know, kind of a key element to understand. And then we could look at, I got some questions about homework 3 in terms of computing these ICC numbers. So I'll just do a quick MATLAB example of how you could set it up. You can set it up however you want, but you know, one simple way of doing it, such that it gives you sort of a vision of how that would go. And then I'll make a pitch for somebody to review this paper that looks at bias and how that affects your sensitivity and specificity numbers when you choose to get the truth data on a sub-selection of the patients that are in the whole cohort. So it's kind of a hodgepodge of stuff today, but let's just start with PET CT stuff. Oh yeah, sure, question?
So have you decided whether or not
Oh yeah, so the question is the midterm going to be online? Short answer is yes. And I will figure out how to do that between now and then, right?
Be like just the online, the like one class, or
So what I was planning to do was just at 9:30, we would start a quiz, and you can take the quiz and you can hand it in to all the way up to whatever the class 1050, right? Just submit it and then we're done. So it's going to be, as I said before, the quiz is not going to be questions where you have to do algebra, get out a piece of paper and scribble down some, you know, some calculations. It'll mostly be about just information / knowledge recall from the lectures, right? Basic concepts. Like an example is like, you know, why is PET more sensitive than SPECT? And I'll suppose A, because it doesn't have a collimator, B, because of blah, 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 and stuff like that. So general concepts, and you know, like any test, there'll be a whole bunch of easy questions and then medium questions and a few questions that probably are harder, right? So, okay, so what I did was I went to the literature, the most recent literature I could find anyway, on the use of nuclear medicine in cancer. Like I'm very experienced with cardiovascular imaging, not so much with cancer, but principally PET and SPECT are used in cancer a lot, right? And one of the reasons why you would use nuclear medicine is that you don't really need a high concentration of the agent to stick to the tumor or the lesion in order to detect it. And when I was looking through the PET literature, and now I can't find it again, but it was looking at actual sensitivity, like the concentration required of, you know, fluorodeoxyglucose. And it was like in a picomolar range that you needed to have in the patient to detect it, right? In MRI, when you're injecting a contrast agent, same with CT, you're measuring that concentration in millimolar, right? So we're talking orders of magnitude different in the amount of stuff that gets into the patient and sticks in order to detect it. Granted, the influence in MRI of a contrast agent is huge. I mean, it transforms the signal by factor 2 or whatever. So this slide here, let's go into, this is just planar scintigraphy. So this is like SPECT, but you don't move the camera. You just keep it in one plane, right? And this is the way nuclear medicine started back in the 60s, perhaps, something like that. And you made the spatial resolution in the XY plane. This way, so the left, right, anterior, or superior, inferior direction. You made that resolution higher by making an anti-scatter grid, right, which with pinholes sort of looking down at the patient. Okay, and so you're truly at every spot on this image, you're looking straight down at the patient. And in this case, I get my, oh, that's a pen. Put the arrow back. Okay. Get rid of this. Sorry. So here they injected iodine, right? And it's radioactive iodine, and it accumulates in the thyroid of patients. Okay, and it's not only used to image the fact that the thyroid is hyperactive. You can inject a type of iodine that accumulates in the thyroid and has nuclear decay that gives off therapeutic energy. And so you actually do radiation exposure of the thyroid using the iodine. So this is the first in a long line of methods called theranostics, where you have an agent and through some antibody or something, you make it stick to a target or a tumor. And originally you might have thought, well, if we can stick this agent to a target, to our tumor, then we can image where the tumor is. Then the next question is, well, you're already at the target. Why don't you load that thing with something that explodes and kill what's there? And so this is one of the first instances of this. And this is prior to the therapy being administered, and this is post-therapy being administered. So it's 7 days after the oral administration of radioiodine. And it shows the biodistribution in the thyroid remnants here, right? And it also shows a buildup, in the liver and the gastrointestinal tract. So this is remarkably low-tech imaging, right? You just need a set of detectors above. Like, it's very inexpensive. And this agent they can swallow, actually, right? So there's really nothing complex to it. And so that's been around a while, and it's still used, especially in thyroid cancers. Right? So for each one of these, they should have a link here to the original source of the paper. So, breast cancer is one of the most common cancers, and for all cancers, actually, one of the critical things that occurs when it's discovered that you have cancer is you figure out, is it a stage 1 to stage 4 disease? Because usually somewhere along that spectrum of stages, there's a change in therapeutic strategy, right? So if you detect the tumor at stage 1, you can do local drug delivery, maybe local radiation, and maybe you don't need chemotherapy for the whole body, right? As the stages increase, usually that means the primary tumor gets bigger, and you see that there are other metastatic lesions in other parts of the body. Common places for metastatic lesions to go are in the bone, in the brain, in the liver. And so this is one of the most common uses of PET-CT is you now have discovered a primary lesion in a breast, say using mammography or just palpation, and you look and see what stage we're at of this disease. And so here's an example of a PET CT. This is an image of one view. Obviously, it's a 3D data set. This image could rotate in 3D if it was dynamic. The CT image is obtained in the same scan as we saw and used for correction in terms of the attenuation of the radiation from different parts of the patient. And perhaps more importantly, for this application, it's used to determine if a bright spot is a benign accumulation of the contrast or it's actually a metastatic lesion. So depending on its location, that will tip the hat as to whether or not this is a benign process or it's a metastatic lesion in the bone or in a lymph node or in a gland or something like that. So in order to make that position measurement accurately, you want the CT there so that you map the hotspot onto a morphological or a image, right? So in this case, there was a primary tumor found here that could have been found on a mammography. Go down to PET CT, and unknown at the time the primary tumor was found, there's this signal here, which is in the cervical spine. So it's a metastatic lesion that has gone to the bone. And there's a met in the liver, right? And so these are what they look like mapped up on the PET CT overlap, yeah? Oh, I see. So that's a great question. How do you know that this isn't a primary liver tumor and it metastasized to the breast? Okay, so that is just through clinical data and experience that a primary tumor in bone, for example, is a very rare thing. And a primary tumor in breast is a very common thing. And so it's like playing poker, roll the dice. You know, it could be the other way, but it's highly, highly unlikely it is not, right? And that's just from clinical data and experience. So most of that is due to the underlying nature of the tissue that generates the carcinoma, right? And is it a tissue that turns over a lot, that divides and replenishes itself a lot? And is it susceptible to genetic mutations, right? For breast cancer, you can do essentially genetic screening. And there are certain groups and certain mutations you can see in the germline of that person that make their susceptibility to breast cancer, say, 20 times higher. And so then they should have more regular mammograms and stuff like that. Here's another example. And, you know, when you compare this picture, say back to that iodine picture, right? This one, you can see where we've come, right? It's a much better image in terms of spatial resolution and sensitivity and everything. Not only that, this is a projection of a 3D model. It's not a projection of the data by the technique. It's just you've got 3D and you're projecting it onto this. Sometimes if you have 3D, an interesting way to project it, in this case, would be for each ray through the patient when we're looking at this view, the only thing you project back up to the visual plane is, in this case, the minimum voxel, right? And so all of those, you know, these are all single voxels that are sampled through the liver, and it's just whatever the minimum signal was on that line, on that ray. And that's like a minimum intensity projection. If you invert the contrast, it's a maximum intensity projection. And that way you get rid of the overlying tissue. You just see the important signals. It's often used in angiography, for instance, where the only signals you want are the vessels, and your contrast is in the vessels, and so they light up. And so you project those onto a imaging plane and you leave everything else behind. So you obviously have some interesting applications there. So here, again, a primary tumor that looks fairly large, was probably discovered manually. And here it is here, as you can see. And again, metastasis to the bone here and metastasis to the bone down here. These are fairly clear, and this goes back to homework 1, where I think one of the questions I asked was, for one of those little dots on the low signal to noise image, it eventually, quote unquote, disappeared, like you couldn't see it anymore, right? And what does that mean? What's the point of that question? Like, why can't you see it anymore? And it's basically, when I measure a dim spot here, like, why isn't this dim spot called a MET? And it's that the signal difference between here and what you would get in normal bone, that signal difference is many standard deviations away, right? Using the background noise as the standard deviation. So I've got, if I'm making a statistical call and I'm 3 sigma away from the background, I've probably got signal there, right? And so that's how you would call this. Now, physicians also will call things just based on where they are, so that they'll push themselves even closer to the background, and they'll need less contrast noise if it's in the perfect spot to be that thing, right? So there's other issues that go into that. But you can see this signal to noise, if you measured the sort of mean signal inside that, it would be many standard deviations away from what would be the natural background signal of bone, right? So, also, you can appreciate the resolution of this scan in terms of, say, the full width at half max, right? And so this is a scan, when you look at that, where the full width at half max is about 5 millimeters, right? And so just from a Gestalt sense, you look at that, that's the blur that is on that picture. So if I had an absolutely crystal clear version of this picture, and I convolved it with a Gaussian function that has a full width at half max of 5 millimeters, this would come out, and that would be my, image quality, right? Okay, and then here, these are nodes, like lymph nodes in the axilla under your arm. You have a lot of lymph in here, and so oftentimes a cancer will spread via the lymph system to the rest of the body, and so it'll leave also lesions in the lymph nodes. And so this helps make a decision, if we're going to do a mastectomy, do we also take the lymph nodes out, right? Or can we leave them there, right? And so there's a surgical decision riding on that. This is kind of interesting in that here's the primary tumor, which obviously it looks like it was discovered a little late, right, in the day. But here it is. And then there was an actual MET inside the same breast, right? It didn't just grow as a tumor. It actually went over here and started growing another independent tumor over here. We have axilla. There's some metastasis to the axilla. Now, the reason I picked this one is because not all news is terrible, right? So here's this patient with a very large breast, cancer, and this is follow-up. I cannot remember how long it was, maybe 6 months. Let's see. It was 5 months. 5 months follow-up. Following what's called neoadjuvant chemotherapy. Okay. What neoadjuvant chemotherapy is you prime the patient with chemotherapy before you do the surgery, right? And so you try and reduce the mass. This lesion here probably was reduced in mass considerably at the time of surgery. And so it kind of debulks the tumor and everything you have to take out. And then 5 months later on the PET scan, like things look great. Right? Now, you just keep following up, right? And watching, but this happens a lot. You know, people in modern chemotherapy and treatment for both prostate and breast cancer, a lot of people survive now, right? So it's not all bad news, right? And you can actually, yeah.
Surgery, did they pick out every
It probably depends on its location and difficulty of getting a clean border. So if it's small and it seems to be shrinking away with just chemotherapy, then they might leave it alone. Because one of the things you do when you're performing surgery is you cause trauma and you can lose cells, right? So if you're, peeling out a tumor and stuff like that, and some of those cells slough off and then go out into the body, that can actually promote a metastatic, spread of the tumor. So, but primarily you want to get the thing out, right? And some tumors are easier than others in that some of them, the more benign ones, have fairly smooth and easily dissected, boundaries between the tumor and the surrounding tissue, and so they'll just like pull out. And others have all these spicule growths and things like that, and you're never going to make a clean boundary, right? So you just try and hit it with chemotherapy. Yeah.
So if you do like segment algorithm, like that, so you can only
Yeah.
try to use like CT or like tissue looks like tissue.
Yeah, we'll see this in when you combine the PET and the CT, you get the advantage of seeing this high uptake and then seeing its location, right? So you can make an informed decision as to what the type of tissue would be. And so that segmentation, part of it is that, right? So often, if a radiologist is looking at the CT only, they are able to determine that something is wrong, unusual, even though the contrast in the background is absolutely the same as normal tissue. They just look at its shape and say, that thing is not supposed to be there, right? In the brain, it's way easier because in normal people, your brain is the same on one side as the other. And so when you put it up as a mirror image, right, with the central axis like this, you just look at one side, look at the other and say, oh yeah, that's okay. And if you had two tumors, then you'd have a problem, right? They were exactly the same. But most of the time there's like an asymmetry and you can see it, right? And there will be a deflection of something. So that's used a lot. However, for these little mets, like something like this, not a chance, right? It's just based on the fact that the signal intensity on the PET is different. Yeah.
They use single energy or dual energy states.
They use single energy CT.
If they use up dual energy, could they do particular composition and then use the PET?
You could. That's absolutely, you could do that. And the principal role of the CT is for this kind of display and also the calculation of what the attenuation would be, the attenuation correction. And they have to use the attenuation correction because remember the energy of the photon you're correcting is like 511 keV, and your CT was taken at 100 keV, right? And so the attenuation is different, right? So there is a correction factor done there. I imagine you could go to a second order correction fraction. If you did a multi-energy CT, you probably could do a little better. But it's always a trade-off of dose. Like, should you just take another image at the same energy, or should you split it and take it at 2 energies? That's a good point. Most of the CT parts of the PET scanner aren't the state-of-the-art CT, right? They're the CT that gets you this far, right? So it'll be like a 64 slice, 32 slice, with You know, so limited energy on that. Dual energy CT is expensive. And then where we're going next is photon counting CT, which is really cool. It sort of takes it to a new level where you detect a photon and you measure the energy of that photon coming out, as opposed to a light flash, which could have been caused by any old photon, right? Here you have a direct detector that measures an X-ray photon and measures its energy, or puts it into one of 4 or 5 bins. You know. Okay, so this is the good news picture. I like this picture. So here's an example of originally read on the CT as a lung cancer, right? And it's fairly obvious why it was read as a lung cancer if we use our one side looks like the other. Although in the chest it's a little difficult because your heart, you only have one heart, you don't have 2 hearts that are mirror images of each other. Not, well, some people do, but and some people actually have a heart on the right side, like they're a mirror image person. Like everything looks just mirrored, which is really cool. That's not very common, but it happens. So this person, if you just look at the lung field and you say, well, there's this thing, right? This is called in the hyla, which is this area of the lung. There are common tumors down the central part of the hyla. And normally you would get upper mantle, what's called upper mantle radiation. It would just radiate this tumor to debulk it. And so the original call on this thing was, I have a independent tumor sitting out in the lung here, right? And then when the PET CT was done, this is the signal that came back, right? And so obviously there is some, even though there's a dark line here, there's some kind of communication between the tumor itself. It's growing in further centrally into the hyla, because this is all tumor stuff here, right? So that changes how things go. Here you could go in there and surgically just take that thing out, right? This, not so much, right? So it's going to change the therapeutic approach on this. And you know, without the CT, this is what you see on the PET, right? And so the CT really helps put things in perspective where exactly they are in the anatomy. So here's another example of a lung cancer that was, I think the original call here was that this tumor was communicating with the hyla here, and then after the PET, these are different slices here. Up at a higher slice, you see that the central part of the tumor is pretty well isolated from everything else, right? And so that's the target that they went after. So looking at that data together, sorry that this is in the way. If we use CT only, PET only, you know, look at the PET and the CT visually, or integrate. Now, I'm not actually sure what the difference between these two is, but it'll be in the paper, in the caption here. But it's fairly obvious what's going on, right? Is that we're basically reducing the number of false positives, you know, by looking at the CT in combination with the PET. And so the PET will show up a bright spot, and, you know, someone will call it a tumor here. So we've got 10 cases out of all of these cases here in which the CT, they said they overstaged the tumor because the PET was bright, whatever. And then when it was mapped onto the CT and they saw where that bright signal was, they actually took it off the list as a part of the tumor. And so it became this signal here, right? So that's essentially what's going on. As you can see, as you combine the CT, this purple overstaging goes down, right? And and the other way, we seem to be more sensitive at picking up understage things. So we just get the call correct more often. Okay. So this is now not PET. Okay, this is SPECT in cancer, and obviously SPECT is more widely available than PET. It's less expensive, but the point spread function, remember, on this one is really broad, right? And 6 millimeters, 7 millimeters, something like that. And so you get these very, with the SPECT only, you get these very blurry, diffuse signals. And what's interesting now, I'm gonna pop this. I'm gonna read this caption again because this is a really interesting case. So this is an iodine whole body scan with a type of cancer after pelvic surgery. Okay. And so after the pelvic surgery, say the patient colon. Okay. They see this thing here, right? And now this is right on the hairy edge, right? If you were to, can you guys even see that on the screen? I don't know if you can see it, right? So even if I turn off the lights. Right. So it's right on the border of what you would detect as a positive accumulation of signal. It's a little ball of signal right here. And what it is, oh, sorry, I should talk into here. So this little ball of signal right here, when you map it back onto the CT, it shows up out here. And, this is the patient's, on this, it should be their right side. This is actually part of their colon. And it's displaced all the way out here because they've had surgery in which a whole part of their sacrum here was removed, right? So if you look at this side and this side, there isn't one over here, right? So that's our rule. So it's been taken off. All of this tissue has essentially migrated this way. And so it pooled this signal to look kind of like a lesion, right? And so when you go back to the CT, you can look at this and say, oh, no, that's not going to be a tumor, right? It's right inside their colon. So again, this is SPECT. You can see the difference between the SPECT images and the PET images in terms of the spatial resolution, right? You've got these horrendously blurry pictures. However, with accumulations of the contrast at key areas. And what is this one? It's like, oh, I see. So this is an accumulation of a contrast agent, but it's not related to tumor occurrence after this person had pancreatic cancer, a GEP tumor. So this is in the gallbladder, right? And kind of skin contamination in the right pelvic region. So this is a skin contamination here, right? So basically, the CT is being used to rule out these bright lesions as recurrent tumor by mapping them to the physiology. Okay, and you can see in SPECT, it's relatively important to do that because for this image, you just have a dot in space. Basically, it's a bright blob. You're saying, well, what's that bright blob? Right? Same thing, here for a hilar tumor. So this is probably a lymph thing. It's parathyroid scintigraphy with sestamibi, and he's got recurrent primary hyperthyroidism. Okay. Okay, well, I'll just let you read that one. Sorry, I knew these when I put them in here and I've forgotten. Okay. Okay, this is an interesting thing you can do with SPECT, and it's called a VQ scan, and it essentially measures the amount of blood flow to the lung tissue, and then the amount of airflow to the lung tissue. And the airflow is image. Let's do that first. Here's this agent is put in an aerosol, and the patient inhales it. And then after they've inhaled the agent, you make a SPECT picture, right? And where there are dark spots, say right here, so this aerosol went to their right lung, went to the lower left lung, but right here, you see there's a dark spot, and so the stuff didn't get in, right? And so that means the airways, for whatever reason, are closed down at that location. And the way this is used is to diagnose people with essentially, embolisms, pulmonary embolisms. And so if you've blocked off the blood flow, but the airflow is still there, then you know it's a pulmonary embolism. It's something that's blocked off the blood flow. If, on the other hand, when you do the aerosol and you see there's a dark region there, you can't really expect the blood also to be upregulated at that part of the lung. So it's when you have this mismatch between the airflow and this agent, which is done normally with an injection, and that goes into the bloodstream, that mismatch tells you that you've probably got a pulmonary embolism. And we can see over here, right, where we have a low flow region from this flow agent, but it also, it happens right in the same place. We have a low respiratory region in that agent. So it's probably not a pulmonary embolism, it's something else. In fact, I think in this patient, when they went back to the CT, or when they went to the CT, they saw a large, bulky tumor that was pressing against the lung here, and it was cutting off both the airways and the vessels, right? And so it was like a mass effect of this lesion. So this has been around a long time. It was the standard of care for looking at pulmonary embolism, right? So if you came in with really bad chest pain and all of the other indications were lined up that you were going to get tested for pulmonary embolism, they would do this. Nowadays, that's not usually done. You would do a high resolution CT image of that patient, and you would look in the individual vessels in the lung for a dark signal, which is the embolus, and you would just identify it that way. That's the most accurate way to do it. Okay. So any questions on those? That's it's sort of a short sampling of PET CT and SPECT and cancer, and there's papers in the module that I put in there for interesting papers for you guys to either do a report on or to read, and so some of them are in there. And a lot of the images that were taken there came out of review papers, which have many different other examples, right? Okay. The other thing I wanted to look at quickly and make a pitch for somebody to look at this paper if they wanted to. So let's get rid of that. And it's this guy. So it's the effect of referral bias on figuring out the sensitivity and specificity for some imaging test. And in this case, the imaging test was nuclear medicine or SPECT. And so they took 10 years of data. They had 14,000 patients in this data set. So this is not a small study, right? And the remarkable thing is, like, SPECT, because so many good papers were written, or so many papers were written that had good results for sensitivity and specificity, this technique took off. And it had, you know, a number of very, and still has a number of very strong proponents for its use as a frontline diagnostic test for coronary disease. And so this paper came out about in 2002, so 20 years ago. So it's kind of like a, well, just hold on for a minute, because we should look at those studies and see how they were performed. And so in this case, so these are patients who walk in the door without known coronary artery disease. So they haven't had disease before, and they're, you know, they're not patients who are having a heart attack. And then coronary angiography was performed in 2000, approximately 2,000 or 13% of those patients afterwards. So now you have a set of patients you've got your nuclear medicine scans on. You've got a set of patients, subset of those patients that you have that quote unquote truth. Okay, so we have the truth data now, because the coronary angiography will show if there's a critical stenosis in a lesion or in a coronary artery. And so that, and then you would act on that by putting a stent or doing bypass. Okay, so that's the whole stages there. And so the apparent sensitivity and specificity and likelihood ratios of SPECT were determined in these patients and then adjusted for referral bias. So the overwhelming majority, 95% of patients who underwent angiography had abnormal SPECT images. Okay, so herein lies the rub. You now have a group of patients that you've performed your SPECT imaging on, you want to evaluate its sensitivity, and you only have the truth data in this group, right? And that group, turns out that most of them had disease, right? So now you, at this point, the study is kind of broken, right? Because you're only looking at people who, for whatever reason, went to coronary angiography. So there will be other reasons why those people went into that bucket, like the head clutching pain, or they, you know, are of a certain age or whatever, not just based on the SPECT result, right? So anyway, when you calculate your sensitivity with this data set, you get 98% for obvious reasons, right? Because it's so heavily weighted towards people that have coronary disease on the angiography. The specificity was very low, right? Because, well, they didn't have many patients to test for false positive. And then they said, well, look, we need to normalize for this effect, this fact that all of these people are coming in. And so they perform a adjustment for referral bias. Now, this is where, if you wanted to enlighten the class, like, how is that adjustment rational? Like, is the formula that they're using here a rational way to do this? And does it give the correct number? And so after this adjustment, it's like 65% sensitivity and 67, you know, somewhere around 70% specificity. And which is actually the number that you get when you do this study right? So let's just think about it for a minute. How would you do this study correctly, right? What would change here? It's a really, really simple change. basically, the problem with the study is the selection of people get coronary, right? The coronary angiography, the truth. You need to do coronary angiography in everybody, right? That's the way you do the study. Is like, regardless of your outcome on the SPECT scan, right? You still get an outcome on the SPECT scan, is whether you're positive or negative, but it doesn't matter. You go and get the truth data. At that point, you can then actually evaluate sensitivity and specificity. Many SPECT sensitivity, specificity papers and trials were done this way because you just didn't do coronary angiography in everybody. It, in some ways is kind of unethical, right? You're saying, why should we do coronary angiography in people we do not believe need it, right? Well, actually, when you do it, you find out a lot of them did need it, right? And your test missed it, right? And so when you look back at that PROMISE trial I showed you and the ischemia trial where they did it in everybody, didn't matter, you just got it. Well, in PROMISE actually not true, right? They did peel off some folks who were called normal, but at least you had an alternative arm, right, in which those people were evaluated. So that's and medical literature is just overwhelmed with papers that have this kind of bias in them. And people just publish them, and large decisions are made on this stuff. So if anyone wants to look at this, I think it's a really important point to understand medical literature, not just for imaging, but for all medical literature, like all testing strategies, right? Okay, so that's my pitch. Now the next thing I wanted to do, just a sec, sorry, yeah?
If you randomly select from the whole group some part of it, so because like they choose for whatever reason some part, 13%. If this 13% is randomly selected, would it still be biased in terms of?
Well, if it's true random selection, that's the algorithm. It should get rid of that kind of bias, right? So if people come through the door, regardless of what I read on their SPECT, I just send them to cath based on a flip of a coin, then that should be okay, right? Because it didn't bias my pool of patients that I'm actually calculating sensitivity on.
What's the minimum percent of the total patients that usually count?
Normally, it's not so much a percent of the total patients as it is just the raw number of patients. Okay, so as the number gets bigger and bigger, your confidence intervals on the sensitivity and specificity get sharper and sharper, right? And you asymptotically go to some value that as the number of patients increase. And that's often called power analysis, right? And when you write a grant, you say, oh, we're going to do 100 patients. And by the end of it, we'll tell you whether or not this one's better than that one. The power analysis, what it does is it simulates for N how the distributions of this patient group and this patient group get narrow, like essentially the estimate of the mean goes down. The other thing, though, that's very interesting about medical research and publications and decisions based on these kind of results is that the null hypothesis is often that, let's just take a drug and say this drug will on average lower blood pressure by 15 points, right, or 10 points or something like that. And you get this huge distribution of values in one group and a huge distribution of values in another group. And it basically, it pretends that a patient, like the question you then ask is, does this have any bearing on what I should do with my patient, with an individual? Because the drug in that individual might work wonderfully, and in this individual might not work at all, right? And so normally the decision is based on the population mean. And the only people that care about the population mean are Medicare, the health insurance company, people like that, and the drug company. So if the drug company says to Medicare, oh, you can take the population mean and push it to here, then it gets approved. However, for an individual, like say it didn't push the mean down, but there's a certain group of individuals in whom that drug works wonderfully, right? They should get access to that drug, right? And so that's the problem, is that, you know, you personalizing medicine when all of your research is done in populations is really tough, right? And then you run into the conundrum that, okay, if we have personalized drugs, how do you make enough of the drug to make it economically viable? How do you sell enough of that drug? So there are both moral and economic implications for all these things. Okay, what time are we at? We're at 10:20. Okay, then what I was going to do first is we'll go back to homework 1. I think it's homework 2. Oh, here we go. Yeah. So there were questions about the definition of SNR, signal to noise ratio, versus contrast to noise ratio, and I realize it's a little ambiguous. Pretty well everything we do in imaging is CNR, in the sense that there is a background signal that your image has, and there is a target, right? SNR, if you had, say, a signal in an MRI scanner or in a PET scanner, and you put that signal in the middle of your imaging device and measured how much, you know, signal came out, right? And you did that 1,000 times, and you measured how much signal came out, and then the oscillation of that signal over trials, that's like signal to noise, right? Most of the time, practically what we do is we measure contrast to noise, because in a single instance of the object, we have a signal and we have some background, like this one, right? So these dots that were filled with a contrast agent that gave off a bright signal gives you a signal value at the dot, and then the variability of that value we can obtain in 2 ways. One is we can take 1,000 of these pictures and take a pixel and measure the change in the value over 1,000 pictures and get that as the standard deviation. That is the correct way to do it, right? In that it's hard to argue that the variability of this value is not measured correctly by taking the image many, many times, right? The noise source will go onto that value and change it. However, we decided that because our process is stationary and ergodic, right, which is an assumption, we can go over to this part of the image and just measure the standard deviation over here. Because we can see this should have a constant value over space. So every pixel, if I measure, should be the same value. And when I measure all of these pixels and the change in their value, then that's an estimate of the standard deviation. Okay. Any questions on that? So low signal to noise, you can see the variability on the constant background is higher than in a high signal to noise, because we have reduced the amount of variability in the signal. Ideally, in the low signal to noise case, the mean value here and the mean value here will be the same, right? If I did 1,000 trials and I measured the mean value here, and 1,000 trials and I measure the mean of that here, that's going to be the same number. because the amount of noise, so in the left case, we have high noise, and in the right case, we have lower noise. But that did not change the value of this. It just changed its, variability from trial to trial. Okay. When I measure the mean across this, I mean, it should be constant in there. My estimate of the mean will have lower accuracy, right, than when I do it over here, because I have less fluctuations in there. Okay, so that's, and here we're calling it signal to noise because we assume the background is constant, right? And really, it should be called contrast to noise, where this signal level is some value, and then this signal level is some value, and we look at the difference between those two values divided by the root mean square deviation of the noise. Okay. There are subtleties in imaging in the sense that in CT, for example, if you have a bright signal, that means it's an area of high X-ray attenuation. Okay, so many more X-rays are stopped by this object as they pass through than in the background. The fact that many more X-rays are stopped means that at the detector, my counts are lower, right? And it turns out that you're essentially the precision in measuring the number of counts is reduced when the counts are lower, right? So I don't have as many counts to add up to find out what the mean value is. As I get more and more X-ray counts, I can estimate the mean value in that detector better, right? And so, in fact, X-ray does have a amplitude-dependent change in the noise value. For most of what we're doing in these exercises, it doesn't come into play because this value and this value are close enough together that the statistics of computing the mean on the detector should be about the same. They're not identical, but they should be roughly the same. Where it really starts to hurt is when this object is, say, really X-ray attenuating, and say it's a metal, and so virtually no X-rays get through it, then you have a problem, right? So, so here, the standard deviation of the background in the low SNR picture was 27, right? And the standard deviation in the high SNR picture was 14. Okay, so it just, the amount of noise shrunk down. These amplitudes should have stayed the same, right? And so you can calculate the signal to noise for that. Signal to noise of 27 is high. I mean, this is a low signal to noise one, but that's the high signal to noise, right? 57 is huge, right? As we saw, remember the Rose criterion is you're going to get the call right every time if the signal to noise is 5, right? So, and again, here's an example of those histograms, right? You put an area in the background, an area in the background, and this histogram is wider, right, than this one, right? I'm not sure what this is. Okay, everyone got this okay? Yeah, this is it's really interesting, right? You can just measure these things directly if you have a machine shop that can make this sucker. This is a hard thing to make, right? I didn't realize this. We went to the machine shop and said, oh, we want some holes and we want them separated by this much going down to such and such. These are tiny little holes, right? And it's a piece of plexiglass. And the guy in the machine shop who made it, he went through like I don't know, 20 bits or something, because they're so small, right? And you go through that, you shatter. But finally, he made it happen, and it's great. So we get down to these really close together holes. As you can see, you can't even resolve them with this. And the full width at half max of this is probably, I don't know, 1.5 millimeters or something. And so the contrast, like the amplitude between the dark and the bright, just reduces down as the frequency goes up. And here's the frequencies. I guess these are in line pairs per centimeter or something. Yeah, line pairs per centimeter. And so you can just plot that amplitude as you're going down here. So this is like 1 cycle per millimeter right here. Right? And and that's a rough estimate of the MTF of the system. Okie doke. So any other questions about contrast to noise, signal to noise? Most of the time we're measuring contrast to noise. Now what was the other thing? Oh, I know. I got some questions about how to approach homework 3. So let's do that. I wrote up a little thing. You guys are probably much better at MATLAB than myself. Okay. Does that get bigger? No, it doesn't really get bigger. Okay. Can you read this okay? Yeah. Okay, great. So it's the way I look at this is very trivial, right? We're looking at rows, which are subjects. Okay, so, and for each row, I'll have n measurements. And that, the way we always use this in the lab, or we're always asked to do this in the lab by reviewers, is you need to give us multiple subjects performing this analysis, right? And show us that you have reproducibility, good reproducibility, right? And so the way I look at it is we're going to make a matrix. And let's make a matrix that's, say, 25 row, 25 samples, and it has 5 columns or 5 observers, right? In that matrix, we'll put values which have 0 mean and 1 unit for standard deviation. Okay, so this function just makes noise. Okay, that's all it does. And then I'm just gonna scale these down here. Okay. So then we'll take a look at that. So I think it should come up with a picture, right? Okay. So there's our data, right? So we have 25 subjects in our group that we're looking at, 5 observers. And we have 0 mean and 1 standard deviation. So basically there is no relationship here between the subject measurement and the observers, right? They're just random numbers, right? And so if we performed this and every observer was going to get the value 0, and all we did was test subjects that had the value 0, we have no way to test whether or not we're reproducible, right? Because there's no relationship between these points, right? And so when you compute, and I found this thing, a function where you can compute the ICC in MATLAB, and it's this, there's 6 of them, but the 3 that we've looked at in class, the one that we're interested in is this A1, right, for reproducibility. But you can look at the others. So the R value for this is like 0.03, right? Just no relationship right here between the observers and that. And our upper bound is 0.2, lower bound is minus 0.07, right? And that's based on the number of measurements we've taken. So if we, I think if we, let's make this 250 and 50 observers, right? See what happens. So now here's our data set. We worked really hard for 9 years to make this data set. That's a lot of observers, a lot of stuff. Now you can see that it's really 0, right? And the upper bound is 0.1, lower bound is 0.1. So our accuracy now that this is 0 is pretty high, right? It truly is 0. Right? So let's go back. Well, we can stay here. You want to stay here? Let's stay here. Let's close all this. So the two things we can do is we can change the values that are measured in the subjects and say, okay, well, not every subject is 0. Our subjects might go from, the possible measurements might go from 0 to, I don't know, 100 or something like that. What does that 100 mean? It's really all in terms of the standard deviation, right? That's our fundamental unit right now. It's like how many standard deviations away is each measurement, right? So if I look at my rows, and so in this little for loop, sorry, I write Fortran, I don't, that's what it is. We're going to add signal as a function of the sample, right? So let's say we'll go between 50 there. So we have 250. So we're going to go between 0 and 5. This will be our signals, right? Let's take a look at that. Okay, so here the mean value is 0. As I go through my subjects, the mean value comes up to 5, right? In terms of the standard deviation, like that, everything's in terms of that, the scatter on my data. And now I've got a pretty good estimate that I have a reproducible measurement here because the noise across here versus the dynamic range of what I'm measuring, that ratio has changed, right? And if we go even higher, right? So now I have this is my measurement space. These are the possible values over my 250 trials that I can get. And obviously, if you do them, they're going to be in random order. We just sorted them so that they're all sitting here sorted. And now there's no question that this is reproducible because you have such a high dynamic range compared to the noise in your system between measurements, right? We can then go back to 5 here. We can then add noise that is, say, dependent on the observer. Let's say we have different amounts of noise for different observers. We have really noisy observers and we have really precise observers. So how many observers do we have? 50. So let's do 50. So that J is going to go between 1 and 50. Okay, so we see that less noise over here, the noise gets higher over here, right? We've sorted them again, magically. And again, it drops our ICC, right? Because the relationship between the measurement and the noise on that measurement is such that this is what our reproducibility is for this set of observers, right? Because they're noisier, right? And so that you can just, I'm just doing this interactively. You can just make a big old loop and plot things, right? And say, okay, as my standard deviation goes from equal to the scatter on the noise to 1/10 the noise or something, you just plot what the ICC value would be, and you can plot these values too around it, right? So you can show how the confidence of the ICC estimate changes as your data changes. And then you can do things like, well, if I have 25 and I have 2 observers, right? And now I need to change this, right? So one observer's not so noisy and one is, right? And this was 25 over 50. Let's say, I don't know, 5. So that's what my data looks like now. I've got a noisy observer, a not so noisy observer, right? I have a dynamic range of 5 here, 5 times the background standard deviation. And then this says, well, if that's your data, if that's what you can afford to do, right? Because you've got this noisy person and this not so noisy person. And this is the reproducibility they can give you. There's your ICC, and it's not that great. Right. So let's see what happens if we make that 1. So now there's much more dynamic range in our data. There's still more noise on this one and this one, but because there's much more dynamic range, it's, you know, in terms of this, the scatter on the data, it says, yeah, you nailed it. You can add as many as you want, but just with those 2 observers and these 25, if this is the data, then you're in good shape, right? So that was the point of the exercise. I'll post this little snippet of code, and then you guys can present it however you want. It'd be nice. I can't remember what I asked you to look at, but you can also decide what you want to look at, right? This is a very practical thing to know about because you have to do it when you come up with a new diagnostic technique. They always ask you to do this, right? So, yeah.
So how do you explain the negative ICC? So like, I mean, for your first demo, you got like the lower bound is negative something. So it means negative variance. So how do you explain that?
No, the ICC is a ratio, right, of different variances. And so I think perhaps that's a great question, but some of our data was negative, right? So because I have a 0 mean and a standard deviation of 1, there's some negative data in there. So maybe one of the means across the thing was negative, right? So you can get negative values. Now the ICC is, if you look at the formula, right, the top part could be negative, right? It's one standard deviation minus another, right? I think so. So if you like make those variables into what their bounds are, you could probably make an end of that. Now, what does that mean? Does that mean you should do I don't know what it means actually though. I can't tell you what it means. Yeah. Okay. We'll look at it. Let's look at the formula. We'll see what it means. There's a good question. Like, what happens when with a negative? Right. Okay. Any other questions? Okay, great. And then Thursday we'll start the test at 9:30, and you're welcome to come here and write it here if you want, but I don't think that's necessary. If there's news about that, I will send a post, right, as to how.
Professor, so technically for the quiz, is it going to be carried out as a Canvas quiz?
Yes, is the short answer. That's my intention. I'm going to test that, and if there's
Okay, got it. So like, as long as we have internet access, we are able to open the quiz like anywhere.
Correct.
And just write our answers on it, or upload a version of answer if we need to write anything.
Correct. I think, shouldn't it be interactive? I think it will be interactive from what I'm told. So you'll be able to answer the question, you just say, I'm finished, and then you're done, right? Yeah, okay.
Got it. So interactive, it means just enter the answers in like answer boxes on the quiz instead of and upload, right? Because I have done both. Like for some of them, it's like after I write it on separate document, I can upload the PDF, or another one is there are just a bunch of questions that have answer boxes for each,
Right.
and I just type in answers.
I hope this one where everything will be, you should be able to enter your answer. in
Got
the
it.
answer boxes and then just press go when you're done. Okay, that's my intention. Yeah,
It's gonna be on the 1.9 or 1.8.
probably 1 through 8. 1 through, was today 9? Yeah, probably 1 through 8, more likely. Yeah.
It's supposed to be closed notes, right?
Yeah, yeah, should be close notes. Okey doke. All right. Thanks. Hey,
Yeah, I just have some follow-up question because like I'm currently doing the repeatability and reproducibility test of my research, so
oh,
I
okay,
have a
good.
lot of questions.
A lot of questions about that. Yeah.
Yeah, because like for our data, we actually get the negative variance of one random effect.
Oh, yeah.
I think it might be the model of ANOVA. It has a problem. So
Oh, okay.
if I
Yeah,
can-
yeah. Yeah.
so if I
I'm
can-
just gonna
Yeah,
get this